Good morning, everyone. How is everyone? You don't seem to be too good. How is everybody? Good, good.
Need oxygen.
Yeah, I understand, and probably a pint or two later on. My name is Don Sweete. I'm the CEO for SNOMED International. I'm based in Canada. Woo! Thank you. The good thing about Canada is we're kind of in the middle. We say sorry a lot. We say good day, eh? But for us, it's great to watch the elections in the UK and the drama. And then our neighbors to the south are about to have a lot of drama, and we're just boring. So I will try not to be boring in my presentation. Next slide. So we are embarking on, and it will be published later this month. We have a new 2025 to 2030 strategy. We just finished our 2020 to 2025 strategy, and we successfully implemented all but 4 deliverables. This is our mission and objective, and the bottom line is for us is to do something good for humankind. These are nice words that are more detailed, but for me it's about providing value to humankind. And that's what we strive to do every day. Next slide. And these slides will be available. We are a not-for-profit organization. We were founded in 2007. We had 7 founding members, of which the United Kingdom was 1, Canada was 1, as well as the United States and some others from around the globe. Essentially, we own the standard called SNOMED CT. How many people know of SNOMED CT? Oh, the converted, good. I thought I was going to have to go in technical slides with little stickmen and stuff, so that's good. We have spent 40 plus years between ourselves and the College of American Pathologists, who originally developed the standard, and invested over $100 million US into that standard to make it useful for those people on the ground. In our new strategy, we want to be sustainable. And sustainable means that for us, we try to do things more efficiently, more effectively, and at the same time, we ensure that what we're doing is for the benefit of everyone in the world, but most importantly, our member countries, because they are the ones that sit around the table and tell us what to do. We are user-focused. We have 50 members globally. We're used in 80 plus countries. And we're trying to evolve to give easy implementable solutions. One of the things that we're looking at in our new strategy is setting up a global standards hub. And so with a global standards hub, we want the end user to come and fetch a set of standards, and working with our partners, download those standards, be assured that they're the latest version, and they have joint implementation guidance. And one of the ones that we think will probably be first will be the International Patient Set, which is very, very popular around the globe. Next slide, please. I'm not going to go into this in any detail, but one of the things I want to mention is when I came to the organization in 2014, we used to think of ourselves as a standards development organization. I don't think of us as that. I think of us as a product and service organization. The product is SNOMED CT, and we wrap standards around it. So we have free open source tools that people can fetch and use. We have implementation services that are freely available that allow people to ask questions, and if there's a crisis, we'll actually have a small team come out on site. And we certainly have translation tools. And our biggest challenge has been trying to do translations for countries and make them meaningful from a medical context perspective. One of the things that we try to do is be interoperable with other standards. Our goal is to be collaborative with all standards organizations and help play a part, and jointly we can make ourselves better for the end users. Next slide. From the openEHR framework, obviously you have one piece of the puzzle, we have another piece of the puzzle. And we need to work together. And we recognize that, and we want to move that forward. And hopefully within the next little while, we'll have an agreement between the two standards organizations. Next slide. here are some specific examples of where we can work together. We work right now with HL7 on their fire messages, but we also need you, the openEHR community, to actually help us bind things together and make things more consistent. So this is what we're hoping for. Next slide. And for us, it's really about three things: interoperability, data reusability, and enhanced analytics. I should say we're also working with the World Health Organization, and we hope and pray that in the next little while we will have some solutions to allow people to move back and forth between ICD-11 and SNOMED CT. So regardless of what system you use, if you're coding in ICD, you can use ICD. If you get something in SNOMED, you will have a companion ICD code that comes with it. And I'm not talking about maps. I'm talking about a way to eliminate maps which are costly, unsustainable, and wasteful, but actually doing something that you can do on the fly by just toggling back and forth. So stay tuned for that. Next slide. So this is a slide of who we work with now. We have over 40 plus collaboration partners. And the slide is quite small. I apologize for that. But there are different ways that we collaborate with all of these organizations. Some of them are maps, but we've moved to a new model now, and the big one is with LOINC. So with LOINC, we've agreed to have what we call a LOINC extension, which is coded in SNOMED, but the LOINC codes are right beside those codes. We don't map to them. They're contained in the extension. Regenstrief owns that extension. They update that extension, and they do it on our platform. It saves them money. It saves them a little bit of time. We put it through our automated quality assurance process, and that extension is then published. The first preview is already out, but the full extension will probably be out sometime later next year. And in that way, we hope it makes it easier for end users to actually have those two standards bound together in a way that makes it easier for them to use in their environment. So we have linkage tables. GMDN is an example of that. Again, device codes are important in healthcare, and certainly from government perspective in tracking where things may be going wrong with defective devices, and so this is a way to help streamline that process. Next slide. We are a founding member of the Joint Initiative Council. I'm not sure if everybody knows about the Joint Initiative Council, but it is a group of standards that got together a number of years ago, initially just to sit down and have chats about how they can work together, but it's now moving forward, and it actually is really focused these days on the International Patient Summary and how a group of standards can actually manage together and help support that initiative that the G7 and the G20 has anointed the Global Digital Health Partnership to work on. So we are part of that, and certainly there's a lot of documentation on the JIC site about how to implement standards, how to determine what standards to use, and what use cases you should select. So there's a lot of documentation there as well. Next slide. And that is it. Did I get back on schedule? You didn't even have, I'm scared, I'm scared of you.
No, yeah, you be careful of Shalini. Short, sharp, and sweet. So well done, Don. Look, are you happy to take any questions from the room as well? And maybe we can pinch a bit of time for Vince and Raj as well, given we've made up a little bit.
So. I have an open book. Oh, here's a question.
Sure.
Ask away.
Good morning. Thank you for your presentation.
Oh, by the way, before I say that, you can ask me a question, but it can't be a technical question.
Can be a technical question. Okay. No, I don't think it's a technical question. One of the things I notice is that when people talk about SNOMED, they talk from the perspective that as long as we all do SNOMED, the interoperability challenge has been solved.
No.
You've shown on your screen that you see they work together, but
yep.
What would you say to people who present SNOMED like that?
As far as I'm concerned, we're just a piece of the puzzle. And we're a small piece of the puzzle. What we try to do is link a group of standards together. We only play a small part. we are the payload for HL7, and openEHR basically provides the specifications for that truck that carries that payload. We can't do it alone, and we don't pretend we will. So we're just a piece of the puzzle. Other questions? Yes?
One of the problems implementing SNOMED in the past has been the local reference sets, the ref set in the UK. Does the new standard propose to kind of do away with that problem? Will it still be there?
Well, we've improved. Now, unfortunately, the United Kingdom isn't on our managed service, because if you were on our managed service, all those reference sets would be automatically updated. We host 14 countries on what we call a managed service, and we maintain their extensions with those countries. And we have a reference set tool that we're releasing probably in January, which will automate all of the updating of the reference sets. Me personally, I don't like reference sets, and again, I'm not technical. I prefer the terminology because it's embedded in with the hierarchies and it gives you more business intelligence, but
the UK would have to be on the managed service.
they can use our reference set tool if they wish. But the managed service is an easier way to go, but right now they're not. Yes?
Hi, Koray from Eden. I'm just going to ask if the UMLS, the Unified Medical Language System, is still relevant, because we kind of aim to connect probably hundreds of different terminologies and ontologies together, including SNOMED CT to ICD, and it's a humongous task, probably more difficult than sending a man to the moon. So how do you guys?
So here's the issue with that. They take the codes from a number of publications. They have our international release. They have the US extension. Depending on, and I can't answer this question totally, depending on how they update that, depends on whether or not it's relevant. The true source is one that we have, which is the international release. And any organization or company that is doing work in New Zealand or Australia would take that international release first and then take the local extension. And that's the easiest way to do it. It's also the only way that you can properly start to translate between different countries. The one in the United States is certainly relevant from a research perspective, and if you are looking for certain commonalities, but it's not something that should be used to replace the standard. Yes?
As you form relationships with sort of data model standards like FHIR and openEHR, will there be like an official position on sort of pre-coordination and post-coordination of SNOMED terms?
We don't do positions on pre-coord or post-coord. For us, it's really understanding what the end users need, and we leave it to those that are obviously doing the archetypes or those that are doing the messages to determine how they want to do it. We don't post-coordinate. We do, but it's not something we focus on. All of the standard is pre-coordinated. We do have some post-coordination tools, but that's up to the end users. We try to provide as much flexibility as we can. And I should say that, and I didn't mention it, but one of the things we're doing in this new strategy is we're going to modernize SNOMED. And so we're going to make it easier to use and much more flexible. So we started work on that now because we're dealing with a terminology that is 40 plus years old and times have changed. And so we're spending a lot of time looking at how we can simplify things and make it easier. Any other questions?
Sorry,
Yep.
I've already asked one, so if anyone else. But I was just wondering, because you mentioned the interfacing with ICD.
Yes.
People are notoriously don't just roll forward with the next version of ICD, of course. So
Of course
that
not.
must be a challenge to you.
The challenge is really in understanding the two standards. ICD is built for statistical reporting and we're built for clinical care. And so the issue is, how do you have two standards sit side by side with a core in the middle that is not mapped, that can provide that semantic requirement that is needed both for statistical reporting and also for clinical care. And I may be dead by the time that we get done with that, but at least it's a chance to start. And the goal is really to get whoever uses whatever standard they can toggle back and forth to the other one if the content isn't in that standard. Because ICD is very good in some areas, and other areas it has huge gaps from a clinical care perspective. We're very good in clinical care, but we have some gaps in some other areas that we need to fill in. And so it's a work in progress. I think my time's up, isn't it? Yes.
Very well done,
Thank you.
John. Thank you very much. And